Philadelphia chromosome is traditionally considered a very high-risk feature among patients with acute lymphoblastic leukemia. It affects approximately 20% of adult ALL population. Its frequency increases with age. Traditionally, chemotherapy was a backbone, and all patients were considered for allogeneic transplant. But even with allotransplant, results were not spectacular, were not satisfactory, with LFS rates at the range of 30%, much lower compared to pH-negative lymphoblastic leukemia. The situation changed dramatically with the introduction of TKIs that allowed for almost 100% CR rate, that increased the proportion of patients referred for allotransplant, and altogether contributed to much improved LFS rates at between 50 and 60% after 5 years. So far, imatinib is approved for first-line therapy. According to modern protocols, it is combined with low doses of chemotherapy, and still all patients are candidates for allotransplant. But there are recent modern approaches that include immunotherapy, like blinatumomab, in a scheme based on second or third generation TKIs. It seems that such a treatment, which is free of chemotherapy, may allow significant proportion of patients achieve complete molecular remission, and these patients must not necessarily be treated with allogeneic transplant. These are phase 2 studies. We need confirmation in prospective trials, but I believe that indeed with a modern combination of second, third generation TKIs and immunotherapy, the need for allotransplant in this setting will decrease.